Welcome back, everyone. This is a screencast-o-matic recording. This is essentially part two to the reading segments for the lesson on federalism. In this particular part of the lesson, we're going to be looking at the COVID-19 crisis, the global pandemic, and America's role as it relates to federalism. Now, before I get started here, I would like to kind of prove a point. When you think about federalism, the fact is that we're talking about state, local, and federal government sometimes coming together, sometimes not, to handle different types of issues. But with federalism in America and in our Constitution, there are certain limitations to what all three of those tiers of government can do. In fact, the COVID-19 crisis reveals just that, for better or for worse, what works in federalism and what doesn't. So before I read, please go ahead and get ready to answer the key concept questions that appear on your screen. Let's go ahead and get started. The rapid spread of novel coronavirus disease across the United States has been met with a decentralized and piecemeal response led primarily by governors, mayors, and local health departments. This disjointed response is no accident. Federalism, or the division of power between a national government and states, is a fundamental feature of the U.S. Public Health Authority. In this pandemic, U.S. public health federalism assures that the coronavirus response depends on zip code. A global pandemic has no respect for geographic boundaries, laying bare the weaknesses of federalism in the face of a crisis. Cited benefits of federalism include the flexibility to customize responses to unique characteristics of a local population, maintain state budgets, and test new policies. Some states have responded to the lack of national leadership by forging their own paths by independently acquiring essential equipment or collaborating with neighboring states to reopen their economies. Such efforts are necessary, but not a sufficient replacement for a nationality-coordinated effort. When our collective fate relies on speed, efficiency, and unity, federalist ideals fall flat. Divided governance creates unnecessary challenges for residents of states that are slow to act or to take up federal policies. While the Trump administration's coronavirus response has aggravated the pandemic with uneven assistance to the states, funding and supply delays, inconsistent messaging, and insufficient testing, the federal government is limited in its ability to mandate a centralized course of action. But this is by design. The COVID-19 response is divided among more than 2,000 state, local, and tribal public health departments. The Department of Health and Human Services, Federal Emergency Management Agency, and the Centers for Disease Control and Prevention have limited authority to direct local officials to take a united action. When asked about the Eastern and Western states' coordinated response to this pandemic, President Trump asserted that the authority of the president is total and states can't do anything without the approval of the President of the United States. But this is not quite accurate. You see, the power of quarantine rests primarily with state and local authorities, with substantial variation among jurisdictions. Under the Public Health Service Act, the Surgeon General, with the permission of the Secretary of the Department of Health and Human Services, has authority to prevent the spread of disease between states and from other countries. However, the responsibility for other public health functions lies with the CDC, a subdivision of the Department of Health and Human Services that is tasked with hard science, data collection, and surveillance. The CDC's experts generally have no means to enforce public health measures. As a result, each state is separately responsible for responding to a public health event. Once the federal government declares a national emergency, state disaster declarations trigger specific short-term powers, such as stay-at-home orders, and enable the drawdown of federal funding. Resulting state variations have implications reaching beyond infection rates. Lax stay-at-home orders in one area may foil much stricter measures in a neighboring region. For example, Salt Lake City, Utah Mayor Aaron Mendenhall issued a stay-at-home order weeks before Utah Governor Gary Herbert issued a milder statewide decree, delaying prevention efforts in the state's most populous city. These differences are even starker in states where residents across borders for healthcare, such as New Hampshire and Massachusetts. The COVID-19 pandemic also intensifies and reveals long-standing inequitable distribution of power and resources, already evidenced by desperate rates of treatment and morbidity for African American patients. Historically, state flexibility in health policymaking has meant that certain communities, such as poor African American families in the Deep South, have fewer resources over the long term and suffer entrenched health disparities. So as a result, they experience higher rates of asthma and other comorbidities that may exacerbate the severity of COVID-19. As hospitals develop triage plans, racial ethnic minority patients may be deproportionalized for life-saving treatment because of disproportionate burdens of pre-existing commodities. Moreover, the economic outcome in places such as the Mississippi Delta will be extensive, where the most common job is retail cashier. Medicaid eligibility thresholds are extremely low, and healthcare facilities were already struggling. Our public health federalism is questionably adequate under the best of circumstances. Divided governance and policymaking result in predictably disparate health outcomes that vary by zip code. During an emergency, when the health of the nation depends on acting with coordination and cooperation, the failures of federalism come into sharp relief, forcing us to reconsider one of the most deeply held American beliefs, that decisions made closer to home are inherently better. While it is possible for Federal's public health system to respond adequately to pandemic, this would require developing a set of robust federal guidelines for pandemic response that prevent the wide variation that has occurred during the coronavirus outbreak. First, federal standards for local stay-at-home orders should be derived from data-driven thresholds for case numbers, transmission rates as determined by the CDC, and the status of bordering states, which together would trigger states to enact protection supported by federal funding. Second, the distribution of medical supplies and equipment should be systemized with clear data-driven allocation guidelines. Informed by the CDC, the Federal Emergency Management Agency could establish a simple application portal that states use to request supplies, an action that would facilitate mapping disaster need and response more efficiently. Third, the epidemic data collection should be standardized, and additionally, uniform data collection across states would enable authorities to move quickly to make consistent choices as the country moves into the reopening phase. Coronavirus outcomes should be tracked by race, ethnicity, and household income to identify and target resources to areas exhibiting health disparities. So guys, data standards could be operationalized by the CDC through predicating distribution of public health funds on state collection of specific data fields. Lawmakers have called for such a provision in the next coronavirus relief bill. Lastly, support for under-resourced hospitals, particularly in rural areas, is sorely needed. While direct infusions of funding may be a short-term solution, expansion of Medicaid eligibility under the Affordable Care Act is existing. More durable options that is associated with lower rates of hospital closures in rural areas. So as you can see, guys, these recommendations retain Federalist flexibility by allowing states to take actions beyond a federally established minimum standard. Moreover, most do not require congressional action. However, implementing these changes will require enhanced coordination and cooperation between and within government agencies at all levels. Coronavirus disease 2019 challenges the assumption that poor health care for some will not affect the many. But in the long term, implementing robust national guidelines for state-level pandemic responses and providing a uniform baseline level of healthcare access will not only improve equity, but will also help to ensure that the nation's health is protected. So as you guys answer those questions, you should be good to go. Please realize the whole main theme of that reading was to understand how federalism works for us and against us. One humbling thought I want to leave with you is think about this. Despite the pandemic still going on, is it possible that the design of government with federalism in place, with a state, local, and federal government having certain powers, helped or hurt the relief? So, as you answer these questions, once again, feel free to replay any part of this presentation that you might need for clarity, and or reach out if you have any specific questions regarding any of these specific notions that were conveyed here. Thank you very much for tuning in.